We titled this Focus Symposium Critical Physiotherapy, New Approaches for Research, Education and Practice, and our intention over the next 90 minutes is to share some research, some ideas, some conversations and some provocations with you, in the hope that you leave here feeling energized and inspired about thinking critically. Perhaps the point that needs emphasizing at the very outset is that for us, critical thinking is a very positive act. It's not the sort of negative slandering that you hear about in the news or the kinds of cynical undermining that sometimes goes on in professional circles. To us, it is an active, engaged, mature conversation between peers. It's a heartfelt engagement with the tensions that are real for all of us in education, practice and research today. An act of professionals who are confident enough in their history and culture to ask questions about why we do what we do and how it might be different. So we hope you leave here today with a renewed sense of excitement and vigour for the future of the profession, and to regard critical thinking and perhaps the work of the Critical Physio Network as a vitally important positive force for an otherwise physiotherapy. My name's Dave Nichols and I'm the founder and co-chair of the Critical Physiotherapy Network, and it's my great pleasure to introduce you to our international panel of presenters. Dr. Mershen Pillay. Mershen is a hospital-based audiologist and speech-language therapist and an associate professor in the discipline of speech-language pathology at the University of KwaZulu-Natal in Durban. His clinical work centres on the management of people with a range of swallowing disorders and hearing loss. But his work also involves the transformation of rehabilitation as a social and political practice, particularly around practices of decolonization. Our second speaker is Viviana Silva, a PhD candidate and senior research assistant at Griffith University. Originally trained as a physiotherapist in Colombia, Viviana has been working in Australia for the last 5 years. She's worked with Professor Peter Ebeling and Professor Michelle Sterling, and her work is centred on the effectiveness of psychological interventions delivered by physiotherapists for musculoskeletal pain and working across cultural and language barriers. Dr. Jenny Setchell is a postdoctoral fellow both in the physio departments of the University of Queensland and Toronto. She's a physiotherapist, acrobat and human rights worker, and her current work centres around post-structural and critical perspectives of healthcare and focuses specifically on physiotherapy practice in areas like weight stigma, critical psychology and rehabilitation practices. Dr. Barbara Gibson is an associate professor at the University of Toronto in Canada. She is the Bloorview Children's Hospital Foundation Chair in Childhood Disability Studies at the Holland Bloorview Kids Rehabilitation Hospital in Toronto. She is a physical therapist and bioethicist and will be well known to many of you for her pioneering critical research into disability and rehabilitation practices. And finally, as I say, my name is Dave Nichols. I'm an associate professor at AUT University in Auckland, New Zealand, and I've been a lecturer, researcher and writer in and on physiotherapy for nearly 30 years. My own research work focuses on critical histories of physiotherapy and considers how physiotherapy might need to adapt to the changing economy of healthcare in the 21st century. The last thing to say about our presenters today is that they are all founding members of the Critical Physiotherapy Network. And Barbara, Jenny, Viviana and I are currently members of the executive, with Jenny also acting as co-chair and Viviana as our chief Spanish translator. So let me say something about the programme we have for you today. Our aim is to open a window into the world of some powerful and prominent critical thinkers, people who are pushing the boundaries of how we practice, how we think, and how our work is felt and experienced. Today is about growing ideas and thinking otherwise. Today is definitely not about the latest research into the benefits of ultrasound or a practical demonstration of hamstring stretching. Today is about flexibility and stretching of a different sort. To be clear, when we talk about critical thinking, we are embracing a number of definitions, some familiar and some perhaps less so. For us, critical thinking includes the kinds of systematic analyses that we do when we critically appraise research, qualitative and quantitative. The kinds of thinking that looks at our ways of learning, doing and evaluating physiotherapy and asks not only what we do, but what that doing does. The kinds of insights that can be gleaned into the ways power operates in healthcare to privilege some people and some ideas and marginalise others. And the kinds of meta-critical thinking that tries to understand all of these things in the context of a frantically changing world. There is no doubt that there is a growing sense that physiotherapists need good skills in critical thinking. The speed at which we're now seeing traditional healthcare systems and structures dissolve, making us all wonder what kind of physiotherapy will be wanted in the future. The everyday competitions, tensions and boundary pressures threatening our personal and professional security. The rapidly ageing population and the number of people with complex, persistent health problems posing challenges to our traditional biomechanical ways of learning, practicing and thinking. Technological innovations that are disrupting traditional boundaries around and between bodies, identities and communities, raising the prospect of redundancy for a lot of our old ways of doing things. The rapid rise of post-truth, post-human, post-everything worlds that might not be something that we would have chosen, but it certainly seems to be a reality for many, begging questions about the stability of the things that we once held to be true, valid, or worthy. And the growing disparities between those living in stunning affluence and those in abject poverty, provoking us to think perhaps for the first time of the cultural, economic, ethical, political and social implications of our work. These, among many other tensions, suggest that there is clearly a need for physiotherapists to engage in some broader thinking about where their profession is, where it has come from, and where it might be going. The reality is, though, that we don't really prepare our students or our practitioners for this kind of big picture, innovative and creative critical thinking. And so we may lack the tools and confidence necessary to bring about meaningful change. And yet, all is far from doom and gloom. Physiotherapists are quite remarkable people. Smart, caring and creative. And we're seeing the emergence of some really interesting and innovative ways of thinking and working. And clinicians, educators, industry leaders and researchers are asking some really powerful and challenging questions about where we've been and where we might be going as a profession. So today is, in some respects, a celebration of the impetus that is driving some of that work forward. During the presentation, you'll hear us draw on quite a lot of material from outside of physiotherapy. A lot of people in the CPN have travelled outside physiotherapy for ideas and inspiration, and many have found rich seams of knowledge and practice elsewhere. What's particularly significant for us is that many of them are now bringing their learning back, looking for ways to infect physiotherapy with their ideas. What this work points to is that critical thinking is rarely about saying that some things are merely good or bad. Rather, it opens up a subtler realization that most things are problematic on one level or another. Even the most obvious innovations are troublesome, not least because they tend to slip past us without stopping and checking to make sure they really are as benign as they seem. So everything, from the grandest theories to the smallest details of practice, are worthy of critical scrutiny. And the whole profession is a vast, rich, largely unexamined terrain for critical scholarship. To that end, we have presentations dealing with a diverse set of issues today. From exploring critical approaches to research, physiotherapy assumptions about disability, rehabilitation as a colonizing practice, and ways clinical interactions are also political, and the influence of neoliberalism on physiotherapy thinking and practice, we hope to highlight some of the possibilities for critical thinking that all of us have at our fingertips now. So without further ado, I'd like to hand over the floor to Dr. Mershen Pillay, whose talk centres on the question of decolonizing rehabilitation. Thank you.
Thanks very much, Dave. I think one of the first things that I must confess to is that, as you heard in the introduction, I'm not a physiotherapist, so I'm acutely aware of the dangers of speaking in front of probably a full physiotherapy, a room full of physiotherapists, and speaking about your profession or referring to your profession. However, having said that, I'm extremely grateful for the opportunity to do that, and I'm really looking forward to the comments and engaging you in discussion around the issues that I'll be referring to. So like I said, I'm an audiologist and a speech language therapist, and I'm based in Durban in South Africa. And much of what I refer to here has been developed with my colleague from the University of Cape Town from here, whose name is Harsha Cathcart. And these ideas have got a long history. We started looking at concepts around decolonization and re-looking at the political nature of practice about 25 years ago. And some of these ideas that I have here, I'm hoping that those who are particularly interested in them will be able to pick them up again on Wednesday when we have our Critical Physiotherapy Network Salon, where we'll be expanding on these ideas. But for now, what I explore along with my colleagues that are here is how critical theoretical approaches can help transform our practices. I talk about how decolonization as a concept from critical theory can help us prepare learners and practitioners in the rehabilitation professions and help them develop key knowledges and competencies for learners. I'm a colonial subject, working and living in an ex-colony, practicing as a colonially inspired profession. For many of you in the rest of Africa, Asia, Latin America, most of what we would call the majority world, this might be a shared experience. But what of colonization and rehabilitation? In recent times, and relevant to us in South Africa, British and/or European colonizations over for something like 350 years have engaged a pretty violent project of owning lives, land, and everything else. In Africa, since about 1902, 90% of Africa was under European political and economic control. Its violence was felt as local economies struggled and the majority of people became landless and poor. While African nations gained political freedom, one might think that the end of colonial rule resulted in a post-colonial Africa, and that all was well. Many African scholars argue that's not the case, and that a post-colonial Africa is actually a myth, because we continue to live with coloniality. Coloniality itself survives colonialism and continues to infuse itself into our everyday lives. It is maintained not by the Western world alone, but also by us as Africans, or Asians, as Latin Americans, etc., who have become colonized, and perpetuate what we call or refer to broadly as a form of neocolonialism. And I include myself in this process also. While we are all concerned about the everyday visible violence of things like wars, rape, and gunshot wounds, etc., and what we do in our work, the question we ask is, can knowledge be violent? Is it possible for knowledge to hurt, to be violent itself? Knowledge as a social construction has very material effects and is never neutral. We must therefore question the assumptions underpinning knowledge construction processes and ask whose interest does the knowledge serve? This map that you see on the screen represents a world which has been colonized. In this example, and there are other maps, the few white areas that you see reflect only the places which escaped British colonial rule. So for over 350 years, colonial influence meant that indigenous people became inferior beings. Their language, their culture, everything about their lives was relegated to nothingness and was replaced often by what colonial masters intended to be after their own image. The problem with dominant knowledge in rehabilitation professions is that Euro-American knowledge is really focused on technical knowledges, sometimes referred to as positivism. So most of you would have had experiences of going through a positive or an empirical science through your years of training as a physiotherapist, your basic training. And what it means is basically we enforce a science, positivism, or what we could refer to broadly as an empirical science, which is, as the root name would suggest to you, is a science of the empire. And it promotes the notion of objectivity. It promotes only one form of reality, one in which universal, generalizable truths are possible. It is a dominant science, especially for disciplines like ours in the rehabilitation professions, and in doing so, what it does is that it replaces and ridicules anything else, but including knowledge that comes from the global south, like here. Critically, the things we do in the clinical moment, the stuff that we do between the clients and ourselves, are not immune from these broader social, political, cultural processes. And as you would hear from Barbara Gibson and Jenny Setchell's inputs later on, They tell you a bit more about how this impacts on the micro, what I would refer to as a micro-clinical moment. As a consequence of empirically sourced knowledges developed from especially Western countries, local knowledges are killed off. Our worldviews, our truths, which are referred to as epistemologies, are killed off, and Western epistemologies continue to plague places in Africa and across the colonized world. So what we do is we become saddled with this knowledge that really doesn't belong to us. It's not about us and was never intended for us. And we use this knowledge to disempower individuals and communities. However, even more problematic are processes of epistemological mimicry and intellectual dependency of African academics on the global north. So even when and this is a critical point, because what happens is that as professionals, our professional imaginations are captured and dominated by thoughts that come from the north. And this is what we would refer to as epistemic violence. And what remains then is a reproduction of northern knowledges in a southern space. The world that is being created, or just generally if you just look at the slide, what the slide is demonstrating is the inequities in the world across various power dynamics. And this slide, which is looking at extending the settler-native narrative, highlights the power inequities as envisaged by Ramon Grosfoguel in 2007, where he distilled 9 contours of coloniality of power that underpin the current world asymmetrical order, which is destructive to all peoples. This table illuminates some examples, and we know that these troubling binaries and power imbalances, which are part of our everyday lives, have potential to become sites of injustice. So if I added, for example, doctor-patient or student-learner or physiotherapist-client, where would you think this would be? Would it be asymmetrical or symmetrical? And I think many of you would know the answer to that. So in South Africa, what made us rethink this fairmount was the Rhodes Must Fall campaign, which brought into sharp focus that universities were sites of coloniality. While there was a symbolic fall of the Rhodes statue, the question that remained, and what higher education has been grappling with, is what is the purpose of higher education in society? Nahasha Kathar, my colleague from the University of Cape Town, and I started working, like I said, on these issues of transformation and so on quite a while ago. And this current moment, what it did was afford us further opportunity for deeper reflection on especially how coloniality has influenced our past and present so that we can create a future. In this reflective moment, the most disturbing stories we hear are of students who explain how education has become dehumanizing. Similarly, our patients, and I use this word specifically to note our still strong alliance or allegiance to the medical trope used in rehabilitation, our patients talk of how what we know and what we do damages, dehumanizes, and renders their lives invisible. We position practice in this way as a site of decolonization. Specifically, we argue for practices generated with people in Africa or for those in Asia, Latin America, etc., the majority world. And here we argue for a disruptive practice, disruptive ways of knowing, and encourage that we revisit our notions of knowledge construction in rehabilitation. Our professions use positivism excellently to, for example, measure disability or quantify therapeutic outcomes into factors that can be understood. These variables are often manipulated and generalized, sometimes using statistical measures to spread open disabled others' lives. At very best, but arguably performing similar operations, we use things like qualitative research, narrative practices, or even holistic approaches to ironically admit complex people with disabilities within or into our professional lenses. We give them labels, a process that we refer to as disothering, to describe how we produce disability. In doing so, in relation to the dominant mainstream population, we create people with pathologies marginalized and othered, and to borrow from a term from post-colonial literatures, Spivak, who calls this the subaltern. It is this form of colonization of others' lives that's linked to empire and its science that I find particularly hard to digest. It is epistemologically problematic, even though it's a science and orientation that is well established in our professions. So as a form of colonial knowledge, it has been normalized and occupies the minds of journal editors, educators, conference scientific committees like this conference, authors of practice guidelines, and so on. So in short, an empirical science limits our professional imaginations because of its over-reliance on individualized and what essentially remains as biomedical interventions, all of which continue to make services invisible or redundant to most of the world's people. Our science enables predominantly the promotion of reductionism, essentialism, and disothering, all processes that enable practitioners to maintain their power as experts while simultaneously positioning the people we work with as wrong, as deficit, as sick. This colonially inspired version of the nature of our clinical relationships are what we seek to transform as we reposition our care at population level. This change, as we see it, to population-based interventions is a social project. The World Report on Disability, for those of you who are familiar with it, which was produced in 2011, highlighted there's about 1 billion people in the world with disability. It also reported that the majority or economically developing world's peoples have the greatest burden of disability when compared to economically developed countries. World health is on the decline, with the world becoming more and more inequitable. South Africa, by the way, has the world's highest inequities, and we've been rated as highly inequitable for a few years now. And so in South Africa, when you look at who's underserved in South Africa, and we look at the nature or the profile of who the underserved populations are, it's by no surprise that they include people with social disadvantage, which places them at risk for not developing the necessary skills to do things like learn or to work productively. Given our political history, the underserved still continue to be Black South Africans. So as reminded by the World Report on Disability, inequities are actually a world issue. The question that we ask in South Africa, like I think should happen and is probably happening in the rest of the world, is how will we rethink what we do together in order to progress the rehabilitation profession? Well, how would we progress together is the question. And what this little diagram here is showing, and this is done by Ndlovu Gacheni, who argues that for progress to occur in Africa, the processes of de-imperialization and decolonization must work together for dialogue between the colonizer and the colonized in the interest of global democracy. And I add here that as individuals, including myself as a practitioner and knowledge producer, I occupy positions of colonized and colonizers simultaneously. Therefore, my first battle actually isn't with you out there, it's with me internally. The process isn't about dichotomizing things like black or white or gay or straight or rich or poor or male or female or any of these other traditional dichotomies that we have. But it's rather about positionalities and that we construct and how we reflect on these constructions in order for us to stand together to look at solutions throughout. I'm going to show you this, and I want you to reflect on a minute on these pictures. This picture here of Sarah Baartman was represented by the colonizer on the left, and this is Ayana V. Jackson's representation on the right. I want you to think about what it is about Jackson's representations that indicates a decolonized Black African woman's body. How has she decolonized colonial representations of Black African women? But significantly, the thing to ask yourself as therapists is how can we do these things too as rehabilitation professionals? Could we learn from this representation, this form of visual representation about the body? And can we decolonize our relationship with the body? And perhaps we can engage our potential creative freedom. We suggest celebrating African humanism as a basis for rethinking rehabilitation. And we can do this by using things like critical dialogues, critical actions, and providing new ways of doing. For example, the educational process for innovation requires deconstruction of the dominant knowledge and text that we use with students and ask, how will this knowledge serve population needs and the inherent inequities? So there are essentially three core enablers that we make reference to. The first is that of developing people as public intellectuals, so, through a process of deconstruction. What's listed as compassion here is about recognizing the need to understand that change, transformation, brings along things like fear, the fear of change, and knowing how to deal with that sensitivity is something we need to do as professionals. The second enabler is this, which refers to dialogic learning. So this kind of conference, this conversation we're having is a critical conversation in terms of how we collectively engage issues of social, political, cultural relevance toward change. And so as we transform, part of what we need to do is to look at how we change our collective, our traditional pedagogy. And within that, looking at where we teach is critical, and that's the third enabler. So literally going into a community and replicating exactly the same kind of therapy practice you would have done in a hospital doesn't necessarily mean change. The idea is to look at how one responds to context specifically, and I'll give you an example of this later when we have a discussion. And the last few points that I'd like to say here is that there are several knowledges and competencies connected to what Hessels and van Letter refer to as Mode 2 learning, where basically knowledge of equity and competence, having competence in knowing and recognizing what inequities look like, knowing things like populations, how do you read a population, how do you work with a population, developing that kind of literacy is critical. Political reasoning, how much of who we are as professionals do we know of the world and of its people and its politics? And things like innovation, what actually is innovation? When you talk about new, novelty, innovation, what does that mean in terms of our practice? These three enablers are critical in terms of the way we think practice should transform. And I'm going to thank you at this minute, and I'm going to now hand you over to my colleagues, Viviana Silva, who will extend these big, broad issues of things like decolonization and she's specifically going to refer to neoliberalism from a physiotherapy practice perspective. Thank you.
So I will continue with the discussion around political reasoning, but talking about neoliberalism and its impact on physiotherapy practices. Similar to Mershon, as he described it in his talk, who I am, where I come from, and the fact that I have experience across 2 different countries and cultures in physiotherapy practice and academia has provided intriguing insights of how politics influences both our profession and world health systems in general. I was trained as a physiotherapist in the National University of Colombia, a public university that has a strong sociopolitical approach. Working in Colombia, I gained almost 10 years of experience in clinical and research before moving to Australia to study a postgraduate certificate. Currently, I am completing my PhD and teaching at the Griffith University. During my working years in Colombia, I found it difficult to nurture and develop my career in a consistent and structured way due to significant political overhauls of the healthcare system. These political overhauls eventuated in major deteriorations in the conditions of the healthcare environment for both patients and practitioners alike. I was morally unable to accept working conditions which significantly increased patient numbers and compromised quality of patient care, giving greater priority to the wealthy and less to the poorer classes. When this was raised with my employers, they were unwilling to negotiate better conditions, which pushed me into running my own practice and volunteering to provide the care I believe was required. Eventually, this situation led me to relocate to Australia. After 2 years in the CPN and reflecting on my career, I began to understand how the socio-political and economic influences were in play. Ultimately, this led me to where they exactly wanted me to be. This was the neoliberal ideology that had me trapped between staying put and providing for the rich, or migrating to a developed country in search for something fairer. I will explain briefly to you my own process of critical thinking during my career, which has been greatly reinforced during the last 2 years that I have been a member of the Critical Physiotherapy Network. Critical physiotherapy strives to challenge and improve contemporary theoretical and practical approaches to physiotherapy by promoting critical informed thinking and encouraging cross-discipline collaboration, currently uncommon in mainstream physiotherapy. In this vein, I draw on politics, sociology, and economy to explore some historical and contemporary sociopolitical forces in conjunction with my own personal experience in Colombia that situated such ideology as a threat. Health professionals worldwide can learn from successful and unsuccessful examples of the implementation, management, and outcomes of neoliberal policies initiated by governments in different countries. I would like to present to you reflections of my experience with neoliberal ideology and how its political structures constrain or enable physiotherapy care, not just for Latin America, but for all countries around the world. Before I opened my own practice, I started my first job in a private hospital back in April 2000 with a salary around $500 American dollars a month. I moved on to working the night shift and my salary doubled due to the extra pay entitlements and penalty rates. However, in 2001, the Colombian government began to implement neoliberal reform, which eliminated all the penalty rates and benefits for the employees. Consequently, my salary was reduced by 75%. Before I opened I used to treat patients independently of their economic status. But due to the reform, it had become no longer possible because of an austerity-based system which increased levels of growing inequality and thus the difficulty in accessing these crucial services. Consequently, a two-tiered system was established where the government was no longer ensuring equal access to healthcare services for all citizens. We are left with a distinct and growing gap between classes that intrinsically segregates between those who can afford to financially contribute towards their health care and those who cannot. Furthermore, the hardest shift is further increased due to the high rates of unemployment and or increase the cost of the contributions. The long-term result is an exclusive private healthcare system that profits from those that can afford its services. This exclusive system still requires public funding to operate, yet does not provide for all. I started to become more interested in the sociopolitical and economic processes involved with the neoliberal ideology, foundation and implementation. Neoliberal ideology is a political and economical philosophy whose fundamental idea is to minimize public costs and privatize as many welfare services as possible. It strives to emphasize individual freedom, especially in acting and expressing oneself freely. In the context of healthcare, from the 80s to now, neoliberal government models have moved to reduce medical services. It eliminates or reduces public funding, patient rebates for physiotherapy, chiropractor, and other kind of therapies. It cuts government-funded pharmaceutical programs, closes hospitals and long-term care facilities, cuts services in some facilities and beds in others. Benefits provided to the disabled and elderly people in many countries are also removed. In Latin America, it started with the inefficiencies and inequities of their healthcare systems that were accentuated by the economic crisis of the 80s. As a condition for borrowing more money to cover their public debt and taking advantage of the crisis, the International Monetary Fund and the World Bank pressed for neoliberal reforms. They provide technical guidance, loans, and directives to implement reforms. These agencies are examples of how these neoliberalism policies have surpassed providing merely economic growth. It has permeated into our social set of values and actions. These policies entice healthcare consumers or providers to become advocates for its continuation. Jimenez and collaborates stated, today there are more administrators, higher expenditures and medicines and foreign debt as a result of the World Bank and other agencies' loans. The neoliberal restructuring of healthcare in developed countries is not an isolated development and needs to be understood as an integral part of processes unfolding on a global scale. Broad-based changes in the financing, administration, and management of public service delivery are on the way at all levels across of the advanced capitalist countries, under the banner of the new public management. The central point of this reorganization is a shift from the welfare state to a new kind of public administration, whose primary objective is the fostering of a globally competitive economy. Whose primary objective is the fostering of a globally competitive economy. This is touted by the OECD as absolutely necessary by the proponents of the new public management because of the fundamental economic constraints on government today as a positive response to political and economic realities. In a nutshell, this is the global state of neoliberal reforms. Now I want to focus on the situation in Colombia, my country, since it closely followed the 1993 World Bank's report and also Mexico, that followed all the World Bank requirements about decentralization and specifically the effects on physiotherapy. The deregulation in Colombia and other developing countries that followed the neoliberal reforms affected general workplace relations and benefits, increasing casual labor, and this is destabilizing the full-time professional workforce. The reforms worsen the situation not just by putting these new pressures on health personnel and increasing health expenditures, but they have not improved equity or efficiency and definitely have not shown a positive impact on quality. Jomeneres and Collaborate found that after 10 years of privatization in Colombia and 20 years of decentralization in Mexico, public health had deteriorated. People were no longer entitled to receive health insurance or coverage from their employers or the government. They simply couldn't afford to pay for those medical services, which in turn diminished their health status. These situations, ironically, increased public health spending in Colombia from 1993 to 2008, even though the neoliberal policies were created to decrease it. In Mexico, decentralization has had a very high cost and has increased inequity without achieving the proposed objectives. Both countries exemplify two of the many paradoxes of the neoliberal system. You can see in this slide how differently some facts are related to decentralization, which are presented in a recent paper of the journal Lancet 2015. Because of my personal experience, I can confidently argue that decentralization was not the people's choice, at least in Colombia and Mexico. It was a top-down political decision made following the 1993 World Bank's report. Both countries' economic downturns decreased financial and human resources to the public system. As a result, services deteriorated, and some felt that major structural changes were needed, including an increase in the role of private insurances, private providers, and decentralization. Many of you will be questioning why the World Bank and other institutions keep pressuring for neoliberal reforms after almost 20 years of evidence against it. Jomeneres and Collaborate suggest that identifying the beneficiaries of the reforms helps to clarify the reasons of the bank's perseverance. The primary beneficiaries are private insurance firms, the U.S. Treasury, consultant firms, universities, and the World Bank staff. If we use a key tenet of critical work, we might ask, what assumptions are held by these people and built into the organizational structures and processes of the World Bank that perpetuate neoliberal reforms in the face of failure? As I mentioned it before, neoliberalism surpassed its function as merely an economic project permeating our social values and actions, and therefore those of the organizations related in some way with its implementation. This ideology has embraced some dogged adherence to believe in market forces and the trickle-down effects of capitalism that are deeply embedded in how the World Bank approaches any issues. Neoliberalism entails both positive assumptions like, for example, the market is more efficient than other institutions, and normative assumptions. The market should replace other institutions because it is more efficient and liberating. So neoliberalism ideology easily transforms the individual's identities and subjectivities, transforming social and moral values and underpin political, economic, and social landscapes. A neoliberal organization with neoliberal values is not going to easily embrace a different approach, regardless of evidence. However, societies are facing so many challenges environmentally, economically, and politically that to continue with a reliance on non-effective economic ideas to solve them is to bury one's head in the sand. Some people have recognized the need to resist such changes, and there have been a number of successful actions to do this in Latin America and elsewhere, all with mixed results. This table summarizes the documented experiences tackling the neoliberal reforms in Latin America. All the successful tools or ideas for tackling neoliberal reform in Latin America have in common strong unions, as you can see for Mexico, proper evaluation by the government institutions of the private initiatives, institutionalization of a free public single healthcare system in the case of Costa Rica, encouragement of broad participation while incorporating both Western and indigenous traditions in the case of Bolivia, Ecuador, and Venezuela, and discussions of health and well-being in relation to society, which is interconnected with sociocultural, environmental, and political economic processes. Finally, I would like to conclude by suggesting that considering political context is essential to practicing good physiotherapy. Physiotherapy programs around the globe may implement changes to their curricula, including perspectives from the social and political sciences. Physiotherapists should be trained with the skills needed to identify, evaluate, and understand different political alternatives proposed by governments as solutions to socioeconomic problems that affect them and their societies. Additionally, we need to strengthen our local association with our participation as individuals for a mutual objective. It is imperative that we and our professional bodies advocate for excellent care and healthcare for all. Thank you. So this concludes the sections on macro politics, and next we will have Jenny Setchet, who will be talking about micro politics. Thank you.
Hi, yes, so as Viviana just pointed out, the last two talks have focused on broad structural factors, colonialism and neoliberalism, and how they affect physiotherapy and healthcare generally. I move from this more macro level of critical discussion that focuses on broader political issues to focus more closely on clinical practice, what could be called the micropolitics of physiotherapy. That is, it's not to say that it's less important by being more micro or small, it's more that it looks into the finer details at the politics of the everyday things that we do. I aim to demonstrate how clinical interaction is also political, and how thinking about socio-political concepts, such as my example of stigma, can help us to attend to factors that are outside physio's usual biomedical or even biopsychosocial frameworks. Thinking outside these frameworks is something I think I've always done, and I'm sure I'm not alone in this here. To me, physio is not just about how far joints move, but also about factors such as both the patient and the physiotherapist's socioeconomic status, their gender, their race, their sexual preference, what types of marginalisation and or privilege they've experienced, and importantly, how these things affect our physiotherapy practice and interactions, or how these things are reinforced or created within physiotherapy. So these considerations have always been an important part of being a healthcare professional for me, but it wasn't until I discovered critical theory that I've found frameworks to help organise and push my thinking of such things. It was during my PhD when I met in person and via reading people who started me off on this aspect of my critical journey. This talk is really like a mini version of my PhD and based largely on an invited editorial I published in Physiotherapy Canada. So I thank them for the permission to share this today. While there have been isolated investigations that have highlighted stigmatisation of various characteristics by physiotherapists, there's been almost no broader discussion about what conditions make stigma possible or salient in the physiotherapy context. Stigma is often defined as occurring when individuals possess, or at least are believed to possess, some attribute or characteristic that conveys an identity that's devalued in a particular social context. However, I'll argue, using post-structuralist readings of stigma, that it's important to expand this definition. Post-structuralism is a group of critical theories that can be used to understand stigma as not something that's not only socially, but also politically, historically, and culturally created and recreated. Seen this way, what is stigmatised or othered, which means turned into something that is other than normal, supposedly, in one context may not be in the next. And certainly Mershon brought this to light in the first talk today after the introduction, that in the context of colonialism can do this, it can other people. Post-structuralism shows that context is important, and I discuss physiotherapy as one such context. Using the example of obesity stigma, I explore some of the nuances of physiotherapy that can be helpful to understanding stigma and may help to reduce it. My presentation also contributes to work that raises broader concerns about the lack of adequate intellectual resources for critical reflexivity in the profession. A few years ago, I'm a musculoskeletal physio, I went to a professional development session to learn techniques to treat the sacroiliac joint. Unsurprisingly, the techniques involve palpation and visual examination of the low back and pelvis areas. Afterwards, one of the physios mentioned that some of these techniques would be difficult to conduct on someone who was overweight. And then another one said in response that she really didn't like touching people who were overweight. She found it disgusting. Comments like these led me to consider what effects these ways of thinking might have on physiotherapy encounters and to subsequently develop an ongoing interest in the intersection between physiotherapy and stigma. The sacroiliac joint techniques that we learnt that day I've used very often since, and quite comfortably on people of all sizes. Would this have been different if I'd thought the techniques would be difficult on people who I considered overweight? Perhaps this perceived difficulty might have changed my competence in using these techniques, or I might not have used them on larger people, effectively denying them a particular type of treatment. And what of the disgust or revulsion towards fat of flesh that one colleague mentioned? Might these feelings affect clinical interactions? It's also interesting to consider how it might feel having your body come under the gaze of a physiotherapist. Having a stranger crouch down and look at your behind and stare at it half-dressed is not something that's normally done in everyday situations in most cultures, I'd say. As we've all heard, probably, and noted at this conference, physiotherapy is a successful and vibrant profession in so many ways, and physiotherapists become a very significant part of many people's lives. Given this importance to people's lives, what we feel and say about people matters. For this reason, it's concerning that there's little discussion about stigma in physiotherapy. As mentioned, what literature exists focus on particular stigmatised attitudes rather than broader considerations of stigma. For example, a number of studies and theoretical investigations, including some of my own, show that physiotherapists inadvertently stigmatise particular characteristics such as aspects of disability, mental illness, persistent pain, and obesity. But they do not look into why, nor importantly, how to address this issue. A number of these authors did note, however, that physios lack an understanding of the stigma people might experience. As one physio in one of my studies said, "I haven't thought about how overweight patients would feel coming to see me, ever." The results of these studies and the lack of literature overall suggests that there may be some benefits to fostering a greater attention to issues such as stigma for the profession, and more importantly, there's likely to be benefits for those we serve. So how can physiotherapists develop a greater understanding of stigma? Post-structuralist approaches help us to think about stigma differently, and a helpful start might be to look at what stigma is and does. Let's delve a little deeper into stigma by looking back at the sacroiliac joint in service I described. You might remember I mentioned two things the other physios said about overweight patients. One was that treating someone who was overweight is disgusting. It's easy to see how this is stigmatising, right? This is overt stigma. But the other comment was that an overweight person would be difficult to treat. This is more subtle stigma. True, the person may be more difficult to treat. But what reveals the stigma is the way that this is said and the comfort with which this is said about certain characteristics. And the tone, perhaps, of blame or even, again, disgust. A pregnant person may be similarly difficult to treat, but we don't talk about it in the same way. A very muscular person may also be hard to treat, but we don't talk about it in the same way. So this is implicit stigma. Defining stigma is more complex than it might appear. I spent a number of years on this. The definition I mentioned earlier and is worth repeating was developed by Crocker and colleagues and is widely used. Stigmatised individuals possess or are believed to possess some attribute or characteristic that conveys a social identity that is devalued in a particular social context. Their definition outlines some of the major components of stigma. It's linked to a characteristic, it involves negative judgment, it's social rather than individual, it doesn't reside within a person or the attribute itself, but it's created in interactions with others. And what is perhaps the most important thing here, or the most interesting thing here, is that stigma is not a static phenomenon. It's produced in some contexts and not in others. That means it's not an essential, stable thing in the world, so it can be changed. Building on this definition, others, particularly those from a critical perspective, including myself through the post-structuralist frame I'm using, argue for a stronger emphasis on the political and cultural creation of stigma. We argue, for example, that certain characteristics are stigmatised at particular times as a product of prevailing ways of thinking in society. Stigma comes from what is considered normal in society at a particular time. And this is linked with systems of power, or as Foucault would have it, regimes of truth. I call this slide Pilates clones. Currently, the neoliberalism that Viviana discussed, which is a prevalent global political ideology, has dramatic effects on what we believe to be true. A good person is seen as one who is economically viable, or one who is seen as economically viable, who doesn't burden the healthcare system, who takes responsibility for their own health, and can be seen to be disciplining themselves, and others perhaps, to do this. There are also critical thinkers that would argue for a stronger emphasis on the embodied material and affective elements of stigma. Focusing on these elements show us that stigma is more than simply a concept or an attitude. Instead, part of stigma is its effect on and of a person's body and mind. For example, high levels of depression and cortisol levels in those who are stigmatised, or the feelings of disgust experienced by those who stigmatise. This type of thinking also reveals that stigma is entangled in the various objects in the various environments. My own research on weight stigma, from my own research on weight stigma, as one participating patient of physiotherapists said when I interviewed him in a physio clinic, looking at the tables that are in most places and thinking how big I was, I would feel fairly uncomfortable on what we're sitting next to, which was a plinth, when I was on that side. That size, sorry. Participants also mentioned the waiting room chair that's too small, posters on clinic walls with images of only thin, sporty people, Pilates equipment as per the previous slide that fits only some bodies, the visible displays of exercise equipment that make one feel guilty, the clothes physiotherapists wear, went on and on. This way of thinking also highlights that stigma is involved in what a person can do and how they can live. For example, reduce employment opportunities, social standing, dating opportunities. In healthcare specifically, research shows that stigma is apparent, for example, in decision-making, in interpersonal interactions, in person perceptions, in the quality of professional practice, the avoidance of healthcare by those who feel stigmatised, effectively denying some people care, and a lack of trust in healthcare providers of those who feel stigmatised, which may well damage the therapeutic relationship. So to summarise, a characteristic or person does not inherently possess stigma. Rather, what or who is stigmatised and how is produced by prevailing social, cultural and political circumstances and is related to objects in the environment as well. As a result, acknowledging stigma clarifies the importance of broadening the focus of physiotherapy beyond biomechanical concerns or biomedical concerns to encompass the psychosocial, cultural and political factors involved in healthcare. Attending to these socio-cultural aspects of clinical practice provides an understanding that physiotherapy often strives to make so-called abnormal bodies more normal by improving, for example, gait, range of movement, patterns of breathing, and increasingly body weight. Physiotherapy also predominantly follows a medical model in which clinicians are assumed to be objective observers. This assumed objectivity that we have means that therapists may not notice their potential for subjective judgments and also may neglect to identify where they perpetuate stigma or may be perceived as stigmatising, which is also important. Even without speaking, physiotherapy projects a particular view of what normal is. And the next slide, you can have a look at what came up when I did a Google image search for physiotherapy, that word, to consider what a physiotherapy regime of truth, as Foucault would call it, might be, and who or what might be seen as other. So, thin, sporty, white, clinical. And you can also see these things on the other slides that I used, partly intentionally, but also partly because that was what was available as a representation of what was what physiotherapy is. Considerations of stigma contribute to concerns that the profession is under-theorised and lacks criticality, and extend the work that is beginning to consider how to address this type of critique. Thinking about stigma challenges some of the basic assumptions and established practices in physiotherapy. For example, the profession's privileging of particular practices, such as evidence-based practice, which reinforce ideas of objectivity, may be reconsidered, adapted or added to. There are small signs of a shift towards this broader approach, with some areas of physiotherapy adopting a biopsychosocial approach. However, even a biopsychosocial approach is insufficient to address some of the important factors I've highlighted to be relevant to stigma, including cultural, political, and embodied factors. There are clear benefits to undertaking the kind of professional reflexivity needed to consider stigma. We're more likely to avoid inadvertently harming our patients by stigmatising them, including excluding certain people from our care. Stigma is complex. There's no one right way of adapting physiotherapy practice that will work in every circumstance. Yet having an understanding of issues such as stigma will help provide physiotherapists with the resources that enable them to better assess the unique situations they encounter. A greater awareness of stigma encourages physiotherapists to be adaptable, to be attentive to the perspectives of patients, and to be more conscious and diverse in their choices of communication and environment. Developing a nuanced critical understanding of the interactional, psychological, social, cultural and political aspects of our work can help cultivate more agile, person-centred and ethical work practices. Thanks for listening. So earlier I mentioned right at the start that some people were influential in bringing me to critical theory. Well, one of them is the next speaker. I read Barbara Gibson's work before I met her. She's a superb critical researcher, applying some complex philosophical concepts to the everyday thinking and doing of clinical practice in child health, and yet very able to discuss her research accessibly. So welcome, Dr. Barbara Gibson.
I think you'll all be glad to know I'm the last speaker, because I know this is a lot to take in. After I'm done, we're going to have some discussion. So my talk is going to focus on the application to research. And what I want to do is go through an example of a critical research project to demonstrate how a critical study differs from other approaches to physiotherapy research and how it might generate different kinds of knowledge that can inform physiotherapy practice. So I am a physiotherapist. I also have a PhD in bioethics, and I mention that because that was my first entry into social theory, which blew my mind and changed my world. At the time, I was working in a pediatric ICU, and I was really struggling with some of the things I was observing in my practice, particularly how quality of life judgments were guiding which patients were offered or even told about life-sustaining treatments. So from that time, and through my PhD, I developed a research program which for the last 15 years has asked why certain practices and ways of thinking have become so pervasive that we don't question them anymore, or if we do question them, we sometimes feel like we can't say that out loud in forums like this one. Questions like, why is independence an assumed goal of rehabilitation? Why is function linked so closely with quality of life in our practices and our measures? And why is return to normal often the goal of rehabilitation? So let me start by talking about what is critical research. And as I said, I'm going to do that through this case example. So this study is grounded in the field of children's rehabilitation, which is my field. And we investigated what our team called activity settings. And we asked, how do different settings make it possible, practical, and/or enjoyable to do different activities? That's a question you can ask in lots of different ways and research in lots of different ways with different methodologies. So for us, activity settings was just a basic thing. It's a place where people do things. And the kind of doings we were interested in were leisure activities that children engaged in at home or in the community. And we wanted to understand how settings shaped the activities of young people. I'm going to go really quickly through the participants and methodology because that's not our focus today. So we engaged 19 young people between the ages of 14 to 23, and all of them had complex multiple impairments. So they relied on multiple forms of human and mechanical assistance, things such as wheelchairs, ventilators, and augmentative and alternative communication systems, or what I'll call AAC. Our methods include a variety of quality of methods. So we accompanied participants on 2 activities each that they had selected for the study, and while we accompanied them, we asked them questions in real time about how it was going and what they thought of it. We took some pictures and videos. We asked the participants to take some pictures and videos as well. We interviewed them afterwards and used those pictures and videos to stimulate conversation, and we sent some follow-up electronic questions. This is a published study, so if you want to know more about the study, you're welcome to access it. So I want to focus on the study framing. How is this a critical study? And you've already heard from Dave and all our speakers about the spectrum of what we mean by critical. What do we mean by critical physiotherapy? So they range, you can see already, they range from that more kind of overt, big P, political questions to Mershon and Viviana perhaps, to the micropolitics of the clinical encounter that Jenny has highlighted already. All of those approaches have in common an interest in how ingrained, taken for granted supposed truths, like neoliberalism or weight problems, influence and even direct human behaviors, including the behaviors of physiotherapists, and as Jenny highlighted, not just individuals, but our profession as a whole. So my research example obviously tends towards that micropolitics side by questioning what is it that professionals take for granted about what disabled children should and should not be doing with their leisure time. What's good leisure time? What's bad leisure time? Do we say sedentary is bad and active is good? Is safety an issue? Why is that our main issue? So in the studies, there were 2 elements of our critical approach that I want to highlight for you. The first one is about spacings. Our analysis was guided by an explicit post-critical lens that draws on postmodern theories, which Jenny talked about, to understand settings as more than static containers, but rather as dynamic spacings that morph from situation to situation, so they're active, dynamic. So it's an important distinction from other health research already, which focuses on perhaps evaluating the static features of an environment and as if they would apply to anyone in the same way. Instead, spacings acknowledge how settings are contingent, they're active. They shape activity, and they're also shaped by the activities that happen within them. So an important piece of that is that settings are more than their physical features, but include the social relations and expectations of behavior within that particular space. You might even think about that in terms of this space. In the study, the relationship between bodies, spacings, and technologies was viewed as particular, always in flux, changing, shifting in the everyday doing of those activities. So activities played out through a variety of, through various sets of relations between people, objects, ideas, places, meanings. What did we think the meaning of the activity was? Another way of saying that is that activities are enabled through a temporary combination, or what we call assemblages, that's a postmodern term, assemblages of elements. So for the study, we investigated how those assemblages were enabling or disabling, and how and what we mean by those things. So the second critical element that I want to highlight is about our analysis. So we drew from what's been called a post-qualitative approach to analysis, which is consistent with our post-critical approach. And we saw the study information as being shaped not only by the perspectives and interactions between researcher and participant, but also through the wider social, political, cultural context in which the entire study, the study itself, is embedded. So analysis was understood as a mixing of all the interpretive acts of everyone involved, and that was shaped by their particular histories, their shared histories, their social locations, and the interpretations of the research purposes to make sense of the experience. Everyone had an idea of why we were there, even if it wasn't necessarily the same as what we told them why we were there, right? People interpret things their own way. So this co-creation was evident in, for example, how participants presented themselves in their interviews, what pictures they took, what activities they chose for the study, and also the researchers, what they took pictures of, what they asked in the moment as the activity was happening. That's all part of the co-creation of the data, but also of the analysis. So analysis is an ongoing, entangled, complex process that tries to deal with this complexity. And so yes, our research team did engage in analytic techniques, so the usual coding, thematic analysis, etc. But that's only a small part, although an important part, of the assemblages of knowledge-producing acts that constituted the resultant narrative. So we didn't have findings, we didn't go out and find something, we created something. So it's a big difference in even the way we talk about it. So I'm going to share with you some of the results, just a very little bit, to try and help get your head around that a bit better. So I'm going to give you two examples of how our analysis of how assemblages function to achieve activity that could be both enabling and constraining, often at the same time. And you'll see that the presentation of the results, again, why is it critical? It moves beyond description. We're not just presenting what people said or summarizing what people said. We're using theory to analyze what we're doing. So the first example comes from Jessica, who was an 18-year-old young woman with complex physical impairments, including she was non-speaking. And one of her chosen activities for the study was playing a video game in the basement of her home with her family. And in the game, Dad and Jessica are partnered together against an opponent. So this is actually them. And the white wheel is the controller for the game. And you can see Jessica's hands on it and her dad's hands are on it at the same time. So Jessica explained to us that this was not a partnership of equals. She described herself as the player. I'm the player of the game, and Dad is the operator of the game controller. So her description of the activity demonstrates how the game play was negotiated, mostly bodily, with some verbal expressions as well, but they did it in a kind of smooth way, and we videotaped it, so it was really interesting to watch how they did this in a kind of an elegant way. And Jessica said, my dad and I made choices. Sometimes I chose and sometimes he did. But we both had to agree. It's very important that my partner listens to me or I'm not really playing. So really playing for Jessica did not mean that she was independently, physically controlling that game console, but rather that she was engaged. And there were acts of cognitive and physical translation, manipulation, cooperation that were negotiated on the ground from moment to moment in a bodily way as part of a larger game-playing configuration or assemblage of people and things in that particularly arranged spacing that enabled that activity. Jessica told us this was a positive experience, but it also demonstrates that hard work necessary from the various actors to really play, using the tools at hand. They figured it out as they went in the space with the tools at hand. Other activities that she talked about required different kinds of work. Some of these were deemed worth the effort and some were not. The second example I want to present is Akash, who was a 20-year-old who had muscular dystrophy and was a wheelchair user. And one of his favorite activities was visiting a local park on his own. And he said, I like the freedom to just turn off my phone and sit there. I can just forget everything and everyone that's bothering me. And also, I love to be free of rules. So while the assemblage of Akash, wheelchair, and park enabled a freedom from others that he told us about, the wheelchair, for him, was also implicated in restrictive safety regimes that constrained his freedom in other ways, which he told us about. So he talked about enjoying a ride in the trailer of, in Canada, we call it an all-terrain vehicle. It might be called an off-road vehicle. You probably get what I mean. But he complained that during this ride, his dad made him wear a safety strap or a seatbelt. And he said, my whole life, I've been wearing this thing, and he shows it to us. He said, I'm not that kind of person. I'm the kind of person that would take risks. I don't want to live my life as a boring person, seeing everyone do awesome stuff, and me doing nothing that's stupid. He said the ATV ride felt so good. Even though I was sitting in the wheelchair with a seatbelt on, I felt like they were letting me go free. So the wheelchair provides physical access to the activity, to the setting, but it's implicated in the quality of that access and what forms of identity and self-expression are available. So if we say that differently, although the wheelchair enabled a mobility and freedom, it limited other ways of doing and being. So these limitations, of course, are not inherent in the wheelchair, which is just nuts and bolts and leather, but emerge through these connections with meaning, with how disability is constructed as deficient and at risk. The body wheelchair seatbelt risk discourse, that's a mouthful, comes together to affect action in ways that both enabled and constrained Akash's ability to do what he called awesome stuff and to be a risk taker. That's his identity. That's who he wants to be. Attaining freedom was this hard work, precious, and never taken for granted. So what? Well, my point, I think, is that critical approaches provide a methodology for making the familiar strange, that in turn suggests new possibilities for an otherwise physiotherapy research and practice. Through mobilizing the theoretical concepts of assemblages and spacings, we identified some tangible ways to set aside prior assumptions to better serve disabled young people. So I'm going to share two of those with you really quickly. First, the research actively questioned assumptions regarding which activities are promoted for disabled young people and why. So Akash's example reveals how assumptions about disability can heighten safety awareness. That's a big part of physiotherapy, right? And in order to minimize risk. The desires and preferences of young people like Akash, but others, that were articulated in the study were to experience freedom, risk, solitude, and other forms of pleasure are not always considered in our institutional and programmatic goals and priorities. Instead, we often emphasize addressing impairments, minimizing risk, or improving function. Second, the research demonstrates creative opportunities for reconceptualizing disability in terms of the possibilities inherent in making and breaking connections. So this is where the assemblages comes in. So we might celebrate attachments or dependencies. Instead of eliminating or reducing dependency, the project instead becomes one of analyzing which spacings or assemblages produce what effects, and working with disabled people and our patients to reflect on what counts as a positive or a negative effect. Okay, I'm going to stop there. I'm going to hand us back to Jenny. I'm sure you're all, we're interested in hearing from you. I'm hoping you're interested in hearing from us as well. Thank you.
So we've got a short period of time to hand the floor over to you. Remember that these talks were just simply examples of ways to think and act critically in physiotherapy, and now we're keen to open that discussion out. We acknowledge that there's a range of experience in this room with critical thinking, from some of you that probably haven't come across it until right now, to some of you who have been doing it for years in your work. So we'd like to hear from all of these range of people. So our question to you for these next 15 minutes or so is, does this stuff resonate with you, with your own ways of working, and can you share some of your own stories about this with us? So there's some microphones around the room. And I'll wrap it up after about 15 minutes to get a summary from the chair, Dave. So there's someone at microphone number 3. I can't see very well apart from the numbers.
I can't see because I'm too damn short. Judgment, stigma. Hi, my name is Louise Remedios. I'm from Melbourne, Australia. Thank you. It's such a privilege to sit and listen to the profession beautifully, gently subvert the word critical thinking. Love it. As I was listening to you guys, and it really emphasized for me, in a sense, how WCPT is in fact colonizing the profession, arguably. And this is sort of brought home this morning. I was at the accreditation session, which was extraordinary, and the conversation about setting standards that are universal and us all moving towards those standards, and who sets the standards. How do we promote global movement of therapists? And their conversations of safety and assumptions that safety can't be done in some places, or are different requirements across the board. I'm not articulating this very well, I'm sorry, but it's that thought of how do we support the profession to encourage, to build a discourse around encourage global movement and still engage with these rules and standards that are being set by a profession with history that is quite a colonized space, I guess.
Great, and that's a beautiful place to end on that question, which is an open question, an ongoing thing to think about. Anyone else? Yeah.
Well, thank you for everything, for your exposures. Muchas gracias. Because
De nada.
I am from Chile, and we are a neoliberalism country, sadly. I have two, first one experience in rehabilitation and the development of CBR, for example, community-based rehabilitation. We are trained by the outcomes evaluation of Ministry of Health. Therefore, we only do what they evaluate, and therefore we only look what they are evaluating. For example, sexuality of people with disability, we don't talk about. We are not formatted, or we don't have formation in that element. We don't have formation for prevent cancer of cervical cancer of women with disability. And that is a critical element, I think. And the other hand is, I think we are in charge, like physical therapists, principally in that strategy. Nevertheless, we work from the ableism. I think we make rehabilitation, but not for social inclusion, or not for achieve the relevant outcome that we must achieve. So can I make a question to you and say, do you think we as physical therapists are ableist, or we have some element of ableism? Thank you.
Okay, and that's a good question. Does someone want to answer that, or do we leave it in the air? Barb.
I don't know if these are on. Can you hear me? Yeah. The short answer, I think, is yes. I think those of you that are familiar with disability studies, and it sounds like you're very familiar with disability studies and disability activism, there's very little of that in our profession. It's coming, it's started, but if you look at our journals, our textbooks, our curricula, there's a smattering of it. The way we talk about disability is still very medicalized, I would say. I'm interested to hear what other people think as well, because it might be different in different places that I'm not familiar with. But certainly if you look at our international journals and curricula, there's very little about the social side of disability and about social justice for disabled people. And it's an area of stigma as well, because we often say it's more difficult to treat those people, etc. So I would absolutely agree that there is ableism within physiotherapy. And there's also some great things that are starting to happen as well in terms of disability.
And there's just another comment from Mershan on the previous discussion point that was brought up.
You may not be able to see me, I'm not sure. You probably see my shining head. Just a comment regarding the universal standards and the setting of standards in physiotherapy. Just want to maybe share with you from within audiology and speech pathology. Since about the late 1990s, there have been several mutual reciprocity agreements that have been drawn up across especially northern countries. So what's been set as universal standards actually benefits mainly economically developed countries and allows or facilitates movement essentially between those countries. And it's premised on the idea that standards can actually be universal, that standards can be decontextualized, depoliticized, decultured, if that makes sense to you. So, and that's something I think as rehabilitation professions, especially working with people's lives, not necessarily working with the thing called the body, the anatomy or the physiology, etc. purely. How do we deal with that, and whether we're willing to accept that as a notion? So in other words, what the profession needs to look at perhaps is to contest the notion of universality of standards, and actually can we have a pure sanitized standard?
Great, thank you, Mershan, that's great. Anyone else?
Hi, Karen Atkinson from the UK. As some of you will know, I'm very interested in disabled students, disabled professionals, rather than disabled, not that I'm not interested in disabled patients, obviously, but I think the work that's done is very much focused, anything sort of trying to contest disability and ableism is very focused on the patient, the client, and my contention would be that we don't generally even think about disabled colleagues. It doesn't sort of translate across, and actually often our ways of dealing with disabled clients is translated straight across onto how we deal with disabled students and disabled colleagues. And so I think that's an area that we also need to think about. Thank you.
Absolutely, thank you, Karen. Someone else?
Good day. I'm Soraya Mart from the University of Cape Town, and I work with Mershan's colleague Harsha Cathard. I'd really like to thank the panel for bringing critical theory into the physiotherapy discussion. But I would like more practical examples of how to approach different thinking within the practice. And also just thinking about the previous colleague's comment of WCPT and promoting a different vision for physiotherapy. And the slide that was up earlier showing, if you Google physiotherapy, what do you see? It promotes a particular discourse for the profession. And I'd like to challenge physiotherapists within the room to provide difference. I think frameworks that have been used lately, and I'm part of the WHO WHOFIC network, using the ICF, provides patient-centered approaches and allows us to see disability and even the clients that we use within a patient-centered and contextual level, so that it's not just impairment-based or a medical approach, but a much broader view. Thank you.
Thank you. Those are great, Amanda. Those are great comments. I agree. The ICF is a huge move away from medicalization and focusing on impairment, and I think it's had a massive impact on our profession and other professions. But it's also been critiqued, right? And many in the room will be aware of that the ICF has been critiqued by people in disability studies, by people within healthcare, in terms of how it still perpetuates a cause and effect model, although it's better. I see some people nodding. That it still sees disability as abnormal and therefore something we should address. And maybe that's not wrong, but we need the counterexamples to think about it more broadly as well. And I'm, again, interested in what other people might have to say about that. Because there has been critique of the ICF, as much as we love it. And the other point I think we want to make about criticality, it's not saying get rid of everything we do. When we problematize something, we're not saying don't do it anymore. We're saying it has other effects too. So let's look at everything that's happening.
Do we have time for one more, Dave? Yep. So time for one more, sir, if you want to. Otherwise, we'll... yes, one more. Great.
Hi. Thank you for your talk today. My name is Sarah Usman. I'm from University of Saskatchewan in Canada. And I just think it's fantastic that there's a space for this dialogue to be happening amongst ourselves as PTs, but to inform our profession moving forward. In my own sort of professional context, I often feel siloed in the thinking in this way, so it's really fantastic to have support of others. And currently, right now in my role as assistant professor at the University of Saskatchewan, I am able to support some of the PT students in identifying their privilege and understanding or acknowledging their unique worldview and how that impacts the relationship that they're going to develop with the people that they work with. But a lot of these students are self-identifying an interest in this, and I find that there are potentially some students and perhaps other colleagues that I work with who are, I wouldn't say that they're resistant to it, but they're so focused on the MSK skills and the technical pieces. So I'm curious too if anyone is able to comment on how do we, is it just continuing this dialogue to try and stimulate more and more people to take on some of these things? Or do we just sort of focus on the group and hope that the groundswell continues? I'm curious what you have to comment on that. Thanks.
Thank you for that comment. And I'll leave it to Dave to sum up and perhaps address some of that to a certain extent. But certainly our stories of people coming to the Critical Physiotherapy Network very much reflect yours. What type of support do we have for this? It's fantastic to find a venue for that in the Critical Physio Network. And the work is really important because most of us, including myself, feel very isolated in our workplaces usually. So, yeah, we'll end on that. Dave was going to do some summarising comments and then we can all have lunch.
Yes, just to reiterate some of those things. Those of you, many of you maybe well know the Critical Physio Network. If you don't, criticalphysio.net. Go on there, you'll find a whole bunch of resources. The approach that we've taken really with the network is to be as diverse as possible through social media, through blogging, through writing, through organising meetings, through having conversations like this. So if any of you want to get in touch with us, feel a little isolated, we all came to the network with that experience of being pretty much people in our own departments. It's a bit like an echo chamber, you talk to your colleagues and they'd look at you in glazed expressions. We've tried to create a very safe place where we can have these conversations, and hopefully that brings about some change. and you'd be very welcome to come along. Could you just join me in thanking our 4 fantastic speakers. Just to close off, I did want to say a thank you to WCPT. There's a great risk in organising something like this for an organisation like WCPT, and I think it's a testament to the organisation's interest in seeing these kind of critical ideas grow. I think part of that comes from the fact that the CPN sets out very deliberately to be a positive force for an otherwise physiotherapy. The positive force is really important, and I think we kind of value that, and I think you've seen that in some of the presentations and the research of the people you've heard today. And also to thank you for your time, giving up an hour and a half of your time on a very busy schedule for this. We expected a handful of people. We probably had 200 people here, which is fantastic, so thank you for that. One of the things that probably I wanted to close with is just a sense of that diversity of critical voices and critical ideas. Probably every one of you in the room have a different critical question to ask, a different context, a different situation. And our hope would be that the network is a space where all of those things get explored. There is no sense of any kind of privileging of any one particular view. It's a very, very broad church. And as Barb said, there are many ways of making things strange. And certainly physiotherapy is a profession that could do with asking some questions and making some things a bit strange, because we do take a lot for granted and assume a lot. So if you do look to the CPN as a place where you might find some kind of community, we'd be glad to have you, and we would love to see you again at some future forum. So thank you all, thank you to the presenters, and enjoy the rest of the conference.